everybody. Welcome. Like Rachel said, we are switching things up a little bit today. I am Heidi Lucas. I'm the executive director of the Missouri Rural Health Association. And today we're going to do our monthly legislative update a little bit differently. In light of ongoing debates and proposed reforms at the federal level, it is crucial to understand how these changes could affect the healthcare status and delivery in our state. So, with shifting towards block grants, per capita funding models, and implementation of work requirements, the landscape of Medicaid is posed to have some significant transformation potentially. These changes could pose challenges for healthcare providers and recipients alike. So today we are joined by Zil Joyce Dixon Romero, who is the State Governmental Affairs Manager at the National Rural Health Association, who will provide a national overview, and Brian Colby, Vice President of Public Policy at the Missouri Budget Project, who will focus on specific implementations in Missouri that we'll be dealing with here that are a little bit different than some of the other states in the country. We'll open up to questions after each speaker, so please ask any questions in the chat or raise your hand and I'll call on you. And at the end of the hour, we'll give updates on any other legislation that MRHA is tracking if we have time. But I know that there's probably a lot of questions and I want to make sure that folks have time to ask them for Zil and Brian as well. So I want to thank you for being here today to engage in this important discussion. We're going to start with Zil for the national perspective and then switch it over to Brian. So I will end my slideshow here. Okay, Zil, take it away.
Can you all see my slides okay? Okay. All right. Well, happy Friday, everyone. Thank you so much to Heidi and Rachel and the entire Missouri team for letting me be here today. I know most of you have probably heard from me or seen my face before in some of these different calls. So I'm just going to dive right into it. But first, I always like to start by introducing sort of the NRHA team, this government affairs team that I work with here in DC. We sort of combine forces to work both at the federal level while I get to engage more actively at the state. What NRHA fights for and with our partnerships is investing in a strong rural health safety net, reducing rural health care workforce shortages, and building rural health opportunities. So that's just sort of the NRHA spiel 1,000 foot level. But that's not why you're here today. You're not here to hear about NRHA. You're here to hear about updates from the administration, Congress, and then sort of the navigation around the potential changes in the Medicaid structure that we've been seeing that may come out of the proposals that Congress and the administration are looking at. Additionally, I'll sort of wrap up with some advocacy tools that we could talk through. So I'll just dive somewhat into it. I always welcome questions, so I kind of put these yellow slides in between. So if you've got questions, just when you see one of these, that's when we'll have sort of end of section, and you can jump in then. Starting with the administrative updates, the majority of the cabinet has now been put together, especially around the healthcare space. Secretary Kennedy Jr. has been in office about a month and some change now. And just this week, Dr. Mehmet Oz, who is CMS Administrator Designate, passed his first hurdle within the Senate confirmation process. So we should see him seated sometime next week is our presumptive guest. Additionally, we also saw pending Senate confirmation for the CDC director and the Surgeon General. And Jay Baccarat was confirmed earlier this week for NIH director. So there's a lot of movement within the cabinet and now sub-cabinet officials that are starting to take place. What we are seeing out of these cabinet officials is their plans for the department, especially around health and human services. The biggest thing that I think most of you have probably heard about or are already starting to feel the impacts of is the $11.4 billion rescission of the CDC public health funding. What this means for us is that the CDC has announced they are immediately going to cut funding for carryover COVID funds and behavioral health funds. And we'll continue to share more as we learn more, including additional resources, advocacy materials, and talking points. But the specifics of the cuts are relatively unclear. The funding that was programmed through September 30th basically lost its last 6 months from functionally the 7th of next month till September 30th with basically no warning. As concurrent as rural communities are preparing for these sort of measles outbreaks and avian flu and other national disasters. NRHA is trying to find ways that we can work and engage the CDC so that we can really emphasize how important some of this funding is for rural communities. But there is going to be a major shakeup with a lot of loss of jobs as well as facilities that are run out of the CDC. Additionally, just yesterday, the Department of Health and Human Services announced that it's going to lay off 10,000 workers and shut down certain agencies within the department. Though we are not specific as to who is getting laid off and where the cuts are coming from, they're a bit unclear, but we did know from their press release that the department is expected to break down somewhat as follows. So it'll be about 3,500 jobs lost at the FDA, 2,400 jobs lost at the CDC, 1,200 jobs at the NIH, and 300 jobs at CMS. Those that are coming out of CMS are expected to focus on workers who are troubleshooting problems that are arising for Medicare and Medicaid beneficiaries, as well as Affordable Care Act enrollees that they feel are getting redundant services. That was part of the sort of press announcement package. And additionally, they did emphasize that the downsizing to where it currently is at is about 84,000 employees down to 62,000 positions, which is what their projected expectations are, will not include the DOGE buyouts that some 5,000-ish individuals took earlier this year, and that will not be included within the restructure process. So HHS says that this will anticipate changes will save about $1.8 billion a year, but they did not give expected breakdowns of who specifically is going to lose positions within those specific departments and agencies. That's just an expectation that we're going to have to kind of look through over the next couple of weeks. Additionally, coming from the administration, there was the expansion of the butyroporphyrin treatment via telemedicine encounters. Their final rule from DEA and HHS was effective on February 18, 2025. The biggest update is that in February, they delayed this until March of 2025. They've now delayed this again until December 31st, 2025. So patients can still get virtual prescriptions through the end of this year through an extension of some of the COVID-19 flexibilities that were also included with some of the last continuing resolution updates. So I just wanted to give sort of an update on that telemedicine encounter and what to look for there. So that's the updates from the administration. I'm going to move into the updates from Congress, which will cover a lot more of the budgeting, and then I'm going to kind of jump down to the Medicaid stuff. So I kind of pulled that out of here. So bear with me as I take you through this very somewhat wonky budgeting process. On March 14th, Congress passed a continuing resolution to avoid a government shutdown. There was a lot of, in particular, press coverage around what the Senate was going to do if they were going to let the government continue funding through past that sort of deadline that they had given themselves. Appropriators say they were close to a deal with Democrats on at least top dollar amounts for military and non-defense programs. And those were the first programs in allowing lawmakers to draft the 12 individual governmental bills that come from appropriations. So that's sort of what we're going to expect in the next couple of weeks and next couple of months to see some long-term spending patches through the remainder of this fiscal year. The CR that came through the pipeline funds the government through the rest of fiscal year 2025 or September 30th, 2025. Some key rural health safety net programs did get extenders through that deadline, which included MDH and LVH programs extending, ensuring that sort of fiscal stability within PPS hospitals. There was telehealth flexibilities that were extended for RHCs and FQHCs as distance site providers. There was also a healthcare at home waiver extension allowing in-home acute care services. There's a series of other funding extensions that came for the National Health Service Corps, CHC, or graduate medical education. But we're going to look with our partners to hopefully during this next sort of appropriations process, make some of these extenders and payments permanent, or at least fund them out through not just in the CR resolutions that happen every 6 to 8 months. Additionally, we've gotten some new key bill introductions, including a few about rural hospital technical assistance programs and rural hospitals acts, which would provide more funding for infrastructure in the House side of things. Additionally, we did see some workforce bills that were dropped around protecting rural seniors and the PAR EMT Act. And then finally, in the rural opportunity space, we did see some Rural Wellness Act and the TREATS Act dropped. All of these bills are bipartisan and have a specific tailored focus to rural. And so just look to see and track on some of these as they evolve, as they may be able to, if enacted, add additional funding for rural assistance directly on the ground. Sort of the final legislative update I'll give from Capitol Hill before moving into Medicaid is the Senate 340B working group. The Gang of Six is a Senate working group that's been re-upped for the new Congress on 340B reform. It was formerly chaired by Senator Stabenow and Cardin, who retired out of the 118th Congress. So the future of the group was unclear at the beginning of the 119th. But Senator Thune, who is now in a senior leadership position as the Senate Majority Leader, is not going to return to the working group, but has allowed it to continue. And so it will have some bipartisan individuals, including Senators Kaine and Mullen from Virginia and Oklahoma, as well as some additional returning members in Senator Moran, Baldwin, and Capito. The group is going to be focused on reviewing and compiling draft legislation from last Congress into a new 340B working group package. But due to all of the Medicaid, Medicare, and entitlements reforms that have been coming out of the Health and Human Services subcommittees, a movement on 340B is still unlikely until that reconciliation and budgeting process has been resolved. What we expect from this 340B working group is that by the end of this year or somewhat into the early portions of next, they'll start to work on a 340B package that they can put on the floor. But many states have already seen the writing on the walls and started to enact 340B protections in their state legislatures. So moving to the proposed Medicaid cuts and rural impacts. Briefly taking you back to high school civics, the budget reconciliation process is sort of where all of this is going to come out of. The budget resolution is needed to start a reconciliation process, and a budget resolution is the document that outlines desired spendings, revenues, debts for the federal government over a specific period. Traditionally, this is something that is due to Congress. The president's budget is due the first Monday in February, and then the budget reconciliation or the budget resolution, my apologies, is due on March 15th. Neither of these things happened in this cycle because of the continuing resolution to fund fiscal 25. And so the House and Senate now have passed their own versions of budget resolutions, and they are vastly different. So both chambers are going to have to pass the same budget measure for it to be enacted, but there is a top line spending figures that are widely different. And when I say widely different, we're talking in the billions of dollars in differences. Largely where that comes from is in the House, the Committee on Energy and the Workforce, and Finance in the Senate side. Of the budget reconciliation package, there is some concerning top-line proposals. The Medicaid reforms is what we're going to talk pretty extensively about today, but additional concerning proposals are the Medicare reforms, including site neutrality, elimination of Medicare coverage for bad debt, and uncompensated care payment reforms. There's additionally a repeal in one of the packages for ACA marketplace subsidies and the elimination of nonprofit statuses for hospitals. NRHA is working very aggressively to make sure these proposals are not included in the final package, but there is some hope in some of the benefits of the reconciliation process. There is a long-term care staffing rule revision. There is also proposals for Medicare physician payments reform, as well as making those rural extenders around telehealth flexibilities, emergency ambulance add-ons, and MDH designations permanent, or at least in a 2 to 5 year cycle. But the big concerning proposal that I think is on everyone's mind is the Medicaid reform. There is the provider taxes, the state-directed payments, per capita cuts, ending FMAP, work requirements, and the repeal of Medicaid and CHIP access rules. So I'm going to work through some of those more specifically. First, how does Medicaid fit into this package? Is that with each committee charged with increasing its deficit spending programs within their jurisdiction, the House Budget Resolution, which is where most of this concern is coming from, has put forth legislation that says that they're going to cut $880 billion out of the committee. In a committee jurisdiction that really is not that large, $880 billion is about a third of that budget. And if you're going to cut a third of the budget, that really only is going to come out of one specific space, and it is going to have to come out of Medicaid. It's unclear how that $880 billion would have reached without touching Medicaid, or at least pursuing drastic cuts. So this week, Budget Majority Leader Thune in the Senate signaled that he wanted to adopt a new budget resolution by April 11th. The House and Senate are still far away from an agreement on a respective budget because the House wants to make these $880 billion in cuts, and Senate Republicans are exploring tactics to make existing tax cuts more cost neutral, but don't really want to touch the Medicaid budget. President Trump told Republican lawmakers as well this week that he would be willing to increase the debt limit if it was included in the package, but it would have to be tied to those respective cuts as well. So the Senate and the House are having a very different argument over this in particular conversation, and budget reconciliation has gotten, well, nowhere, to be frank. On the Medicaid reform proposals, this is what the proposal looks like coming out of the House package. First, they want to convert Medicaid payments to a per capita cut. Basically, the proposal would put a block grant of a per capita increase on the federal Medicaid funding limit, shifting extra costs to the states. State Medicaid budgets are already somewhat strained, and cuts on the federal share may not be sustainable. As a result, states might raise premiums, deductibles, copays, or leaving more low-income residents uninsured. What does that impact look like on rural? What that looks like is the Medicaid block grants and per capita cuts could greatly jeopardize provider stability as well as funding in rural areas. These block grants or per capita would exacerbate the trends by increasing the number of uninsured individuals, creating wait lists, and then reducing the Medicaid reimbursement rate, period. Additionally, when we kind of pivot off of the per capita or the block grant proposal, we'd also see that the proposal states that it really relies on a variety of sources to finance Medicaid programs rather than the kind of well-known split that exists today. The proposal would phase down safe harbor thresholds on provider taxes from 6% to 3% and cap those out by 2028. Additionally, the proposal states that states would be limited in their ability to use these taxes to finance Medicaid, which would force states to spend more on the Medicaid program and reduce federal spending by about $175 billion over 10 years. But what that would mean in cost sharing is that as of 2018, provider taxes accounted for about 17% of the state share of cost to Medicaid. So dropping that limit could base in half would really put a strain on state budgets. The proposal would then phase down these safe harbors, and by limiting those states' ability to use those taxes to finance Medicaid, there would be an impact on rural directly with the restricting use of state-directed provider payments that then threaten the rural providers who rely on the funds to sustain the key services. In the 2010s, roughly 2/3 of all rural hospital closures were in states or in areas that did not have Medicaid expansion as a protection safety net for those rural facilities. Moving away from sort of that structure, what does this elimination look like when it would enhance expansion Medicaid matching rates or lowering the matching rates, or functionally what is known as FMAP? Reducing or eliminating 90% of that federal matching rate on the state level would frankly cripple a lot of states. 9 states, not including Missouri, already have trigger laws that automatically drop Medicaid expansion if the FMAP is lowered. Additionally, 3 additional states also have trigger laws that would encourage the state legislature and Medicaid agency to drop the expansion requirement quota number, which is also not in Missouri, but these are 2 models that already exist, that are proposals that are out there and gaining, speed in gaining traction in state legislatures very rapidly. The impact on rural of this is that when we look at almost 2/3 of rural uninsured populations live in states that have not expanded Medicaid, but among the uninsured rural individuals, about 15% are estimated to fall into coverage gaps. So even if the state is under a Medicaid expansion plan, if the 90-10 matching rate goes away, that gap is going to start impacting states that have expanded, even if they can stabilize their budget. And so what that would look like is we would guesstimate 15% are going to fall into a coverage gap in rural versus 9% in their urban counterparts. Rural hospitals are going to see lower income populations that are less likely to have health insurance because they're no longer covered because of the gap that would then be existing. So that would make public payers more important to hospital financial stability, and the Medicaid expansion with no correlated coverage would then make the finances of hospitals more strained. And so the investment in public payers is usually a strong safety net for rural providers, but the infrastructure would possibly go away under the proposed rule. Additionally, eliminating the enhanced matching rates would show that sort of lower income population are less likely to have that insurance to be covered, making the public payers extremely, unstable. So what does this mean when it comes to the possible scenarios for your respective state? As Missouri is an expansion state, there's basically two options forward as KFF has outlined if this proposal were to be gone through. Scenarios one is that the state's going to pick up the bill. States would continue to fund their Medicaid expansions despite massive cost. This would roughly increase in a 17% expansion in state spending over 10 years. And so that would most likely mean either tax increases or that they would have to cut from other departments. The number could go higher, especially if a pandemic or a recession caused a surge in Medicaid enrollment. And then there's scenario two, which is the state could drop coverage. The expectation there is if a state drops expansion coverage because of the unaffordable sort of $626 billion price tag nationwide, it would remove roughly 20 million people out of their insurance coverage across the country, while removing the coverage would prevent the dramatic cut needed in the state budget. So you would get sort of dramatic cuts and multiple people, almost, hundreds of thousands or even millions uninsured, or your state picks up the budget and there's sort of a tax increase and other services are cut. What this means specifically for Missouri is that plans are sort of being talked about on how you would be able to make that impact feasible. The Missouri Medicaid program told lawmakers in Jefferson City earlier this month that it could stand to lose between 30 to 35 million for every percentage point decrease in the federal matching rate. Well, the state legislature has already started to see some proposals about working on some of those trigger laws. State Senator Jill Carter sponsored a constitutional amendment to require Medicaid enrollees to work or participate in activities so that there would be at least some sort of tactful tax rate that they could add increased funding to the budget. But Missouri and 6 states also, when they passed their Medicaid via ballot measures, emphasized that the state legislature could not pass changes to expansion without voter approval. And so unlike most states where there is that sort of trigger law system or the state legislature can make direct impact, any Medicaid substantial changes is going to have to be on a ballot measure in the next election cycle. And so that could have ramifications if the proposal has gone through. Finally, in sort of this Medicaid conversation, just a couple of quick facts and figures. I'm not going to really go through these, but it just shows the gap that is existing between the rural and urban population, and noting that more individuals in rural are utilizing the Medicaid system. And then finally, I wanted to show this, which is just the Medicaid enrollment by percentage for congressional districts. NRHA has this map up on our website and has additional data around Missouri's individual congressional district, figures and data around Medicaid, if that's something you are interested in advocating for. Well, speaking of advocacy, I'm not going to just give you all of this with no kind of, help in how you can talk about this and converse with your state and federal lawmakers. NRHA introduced a new Medicaid mapping tool, which is the sort of zoom in that I just showed you for Missouri. We partnered with NYU's Langone Health Department of Population Health to create a data visualization board for respective congressional districts to illustrate the total of populations that are utilizing Medicaid in the respective states. And I'm seeing Tim's comment in the chat. Yes, I did mean 22.9%, not 229%. I think that would be a little hefty, and maybe there would be some fraud there. So yes, there is a decimal point in there. Additionally, NRHA has advocacy campaigns specifically centered around the Medicaid cuts and rural impact fact sheet. So we have a 1-pager, a 2-pager, as well as a letter on Medicaid reforms that have to do with the proposed topic and proposal, that have to do with the proposal, as well as topic areas around Medicaid and why it's beneficial to rural. And so when these slides are shared out later, we encourage you to look at some of those fact sheets, as well as the letters that we've presented. Moving on to some additional fact sheets and talking points, we've also created a guide to some of the additional sort of extenders and proposals that are going to come out of the budget process. So we want to make sure that you have options on how you can navigate advocacy and help you with sort of those conversations, especially around the Medicaid cuts. These are meant to be sort of used as like an internal understanding for you and the lawmaker to talk about. Additionally, we have our legislative tracker. Our legislative tracker enables you to look through rural health bills that are in Congress as well as at the state level, in monitoring those bills that NRHA is hoping to has helped either create or endorse, as well as they're done by searchable topic areas, Medicaid of which is one. We also have our press center, which we just launched to help with media requests, as well as anything to do with statements, testimonies, and public comments. The biggest thing I will direct you to on the press center is an updated Rural Stories advocacy resource. NRHA is really encouraging folks to share their experiences with us and what they're seeing on the ground, specifically around workforce shortages, healthcare access, closures, and kind of emphasizing Medicaid right now, how specific expansion policies are benefiting your community. We take those stories and then we repurpose them and have those conversations with lawmakers and say, well, this is someone who works in your district who is doing X, Y, and Z program, and this is the benefit and utilization that they're seeing out of Medicaid. Here's an actual story. And within the sort of form that we ask you to fill out, we ask your name, your congressional district, and if you mind being kind of noted as someone who wants to tell a story, so we can either protect your anonymity or also elevate your story to other lawmakers or the press. So just a sort of advocacy resource that we can help circulate as well. Finally, there are on the advocacy resources, we have a legislative agenda and sort of an appropriations priorities request. I just wanted to share those out with you, as well as NRHA Rural Health 101 and Rural Health Advocacy 101. If you want to help elevate some of your staff to talk about and work through what is advocacy, we encourage you to take a look at some of those one-pagers. NRHA also is going to be hosting a Medicaid specific listening session next week. So if you'd like to really hear most of this information one more time and give it back to us, we do encourage you to be there. But it is something that we are trying to get as broad as possible, just so that we can get a little bit more of understanding what's happening on the ground, so we can talk through the budget reconciliation process a little better. Finally, I would be remiss if I didn't just say, sign up for our newsletter, and you can contact us on, LinkedIn, Facebook, email, Twitter, or X, or whatever you call it, and kind of move on from there. So thank you so much for having me. I know I went through a lot of that very quickly, but happy to take questions.
Feel free to either come off mute and ask a question, or you can type it in the chat. So we'll just give you a second to do that if anybody has any.
And I'm just going to say, Heidi promised me a half hour, and it is on a half hour on the dot. So I'm feeling very confident right now.
Heidi, I'm impressed. Can I ask a question?
Yeah, of course.
Hey, Bill, any update on what's going on with the Senate parliamentarian and the discussion of current policy baseline and that stuff?
Yeah, that's a great question. As of right now, I haven't heard anything new from the Senate parliamentarian's office. We are hearing that at least the Senate parliamentarian is looking into these issues, quote unquote, but it's unlikely that it's going to really materialize anywhere, in my opinion. In my opinion. That's a good question, though. Tim.
Hey, Zil, great job. And thanks, Heidi and others, for doing this from MRHA's perspective. You did a, tour de force of covering this in 30 minutes. Quick question. You sort of pointed out the sort of rural differential here nationwide and in Missouri. What are all you hearing from the Hill or otherwise about how that's playing out in this debate? Is that resonating, that there's a sort of a rural differential in Medicaid?
Yeah, so that's a really good question. And when it comes to those types of conversations, I think from NRHA's perspective, we're looking at it as, here is the data. right? That there are more utilization in rural. And so particularly folks on the left see the Medicaid debate as something that is, oh, we need to ensure that Medicaid stays on. And on the right, they're saying this is the majority of voters that we're seeing that are utilizing these programs. And so is the sort of narrative resonating with people? Yes. Will that materialize into policy changes? Unclear. Good question, though. And it's one that I wish I had a better answer to.
Any other questions for Zill?
Hearing none and seeing none. I will drop my email in the chat. So if anyone has any additional questions, and I look forward to being in awe of Brian next.
All right, thank you, Zill. All right, Brian, you're up, sir.
Yeah, Heidi, I have a PowerPoint. I can use it or not.
Yeah, go ahead. Feel free to share.
Okay, can you guys see that?
No.
No. Okay. Hang on a second. How about now?
No.
No?
There we go.
Okay. Sorry about that. Okay. My name is Brian Colby. I'm with the Missouri Budget Project, and I'll do this quickly and skip through a couple slides. But the impact on the state is going to be really significant if these cuts to the Medicaid program come through. As of right now, our general revenue budget is just over $13 billion. That's going to be significant when we talk about how much general revenue we would have to replace the loss of federal funding to maintain our program as it is. Now, I don't suggest that that will be the case. I think there'll be a lot of cutting that will go on, but we're looking at very, very significant numbers for. And the impact on general revenue could be just enormous. This is just a breakdown of where we get our general revenue and where it goes in the state. I'll jump over to what the impact of some of these reductions could be if Congress decides to go through with actually finding $880 billion in cuts, and what that would mean for the state of Missouri. And it's in several different programs that we heard about or mechanisms that may change. And I'll begin with our provider tax, which we call an FRA. Nobody else does. It's just a way of not saying taxes. But our provider tax is one of the most generous, one of the first, and therefore one of the highest provider tax, which allows us to have a voluntary tax on our hospital systems up to 6% of their revenue. The plan at the federal level would reduce that to a maximum of 3%. So right now we get about $1.5 billion from our hospitals. That is put up and gets a drawdown of federal match of $3 billion. If this was cut in half, we would have to come up with $750 million in general revenue to replace that loss of federal participation in our Medicaid program. That's just the one element, $750 million. This is a fluid number. We're not at 6% right now. We're somewhere a little bit low. But a huge significant impact to the state budget. And there has been talk of actually dialing the provider tax down below the 3%. And so we could be at risk of $1.5 billion of state revenue that draws down $3 billion of federal match that would no longer be available to our Medicaid program. All of this funding is directed straight into the Medicaid program and acts as a replacement for general revenue. So we get to spend it on general revenue on schools and on highways and on other things. This would just mean our Medicaid program would actually suck up a lot more general revenue and would have to cause cuts in other parts of the state budget. if we were to maintain our program, the Medicaid program as it is right now. The other proposal is the reduction of match rate for Medicaid expansion population. We call that adult expansion group, AEG. Right now, the match rate for that, the federal participation of our Medicaid expansion population is 90% federal dollars and only 10% state dollars. The proposal is to reduce that to our level, or our level of federal participation in other parts of the Medicaid program, people with disabilities and home care and other folks. That's a 65% match rate in Missouri. It's higher than the national average because we're per capita a little poorer than most states, and that's how they figure out what that match rate is. So we would see a reduction of potentially 25% in federal participation for our Medicaid expansion population. That's would be a huge reduction. As Zoe mentioned, it's about 30 to 35 million dollars per percentage rate reduction. And so if they were to reduce it all the way down to the 65%, we would have to come up with general revenue of about 777 million to maybe even as high as 875 million to maintain our Medicaid program as it is right now. As Zoe mentioned, we went to the ballot and expanded Medicaid. It does not have a trigger. So we would, and we have a Supreme Court ruling that says the people have spoken, you have to fund Medicaid for this adult expansion group, the Medicaid expansion group. So we would probably have to go back to a vote of the people to be able to reduce that. So in the interim, we would have to find cuts or reductions in the budget somewhere else other than our Medicaid population or Medicaid expansion population until we could figure out how to deal with it. I know it's a little bit complicated, but it would be a severe blow to the state budget. Very difficult to figure out how we would deal with this. Then I'll go on to talk about per capita caps or block granting. It's a kind of a variation of block granting, but it accumulates over time. And so essentially you set your Medicaid block grant or per capita cap at a certain rate. Healthcare inflation goes up generally faster than normal consumer price index inflation. And so the Medicaid program would be slowly kind of starved of that normal increase over time. And so it begins kind of slowly, but would have a very large impact towards the end of the 10-year window, which all of this is being scored in. And so to give an example of what the impact would be, first couple of years would not be felt too significantly, but the average reduction would be about $1.7 billion with a fully implemented reduction. We think of somewhere in the area of about 2.3 billion in fewer federal dollars coming in to support our Medicaid program. So we would have to either cut other parts of the budget, cut our Medicaid program, which is it would be very difficult to do in any meaningful way. And then at the end of the 10-year period, we would have about $2 billion less federal dollars coming into the state. We'd have to make that up somewhere. And again, a reminder, our general revenue budget is just over $13 billion. So it'd be very difficult to come up with these cuts. The numbers for these, we're looking kind of backwards at a proposal from Speaker Ryan about 20 some years ago. And it was Edwin Park and Matt Brodus that did the analysis specifically for the per capita caps cuts. But anyway you look at it, it's devastating, very difficult to figure out how we could go through without significant cuts to all portions of the budget. Analysis is hard to do on this because healthcare inflation is different than consumer price index. Fluctuations in economic growth and unemployment always play a huge factor in what the healthcare spend is at any one time in Medicaid. Of course, when it's counter-cyclical, so when the economy is doing poorly, our Medicaid budget and enrollment goes up. So it's very, very hard to deal with these, but the potential cost that we think is somewhere in the area of 750 million if they go after provider tax. If it's the match rate for Medicaid expansion, 777 million to 875 million, and per capita caps an average of $1.7 billion. Very, very difficult to figure out how we overcome that with a general revenue budget of just 13 billion. The other tough thing about Missouri is that our state revenue is flatlined. We've had a number of tax cuts that are still being implemented over time, but we've kind of broken our revenue system. What this shows is we've had a growing economy, but our tax revenues are flatlined. That's a real problem as we go forward. And there's just not a lot of room to make up for that. That's because we've been cutting taxes at an extraordinary level since 2014. We've cut over $3.2 billion in potential revenues in multiple numbers of tax cuts, some of which are still being implemented. So we're going to have more and more reductions in revenue as we go forward. And then in Missouri specific, we have the Hancock amendments, Hancock 1 and Hancock 2. These have reduced revenues over time. This graph just shows how far below we are when we first implemented Hancock, saying that if we have revenues over a certain amount, we'd have to give it back to the people. Well, our revenues have declined as per capita spend for individuals in the state. And so we are way, way below what that Hancock level would be. But as we passed Hancock 2 in 1996, it requires a vote of the people to get a tax increase of above 150 million on an annual basis. So if we were to raise revenues, we'd have to go in any meaningful way. We have to go back to a vote of the people. That's going to be very difficult to do. So Missouri is kind of has their hands tied behind their backs because we have Medicaid expansion in the Constitution because of the ballot initiative. We'd have to figure out a way to get that unlodged, or we'd have to cut other places. And then going to the ballot for a tax increase is going to be very difficult. So we're kind of hamstrung there. So both situations don't look good for Missouri. Sorry to be a bearer of bad news, but that's what I've got, and happy to answer any questions.
Tim put a question in the chat. Go ahead, Tim.
Yeah, sorry. Great job, Brian. Again, as usual, you always summarize things nicely. So help me understand the provider taxes or FRA again. So you said the cut would be 750 million, which is the general revenue share, but that brings down, as you said, a $1.5 billion federal match. Wouldn't we lose that as well? Or am I not thinking about this correctly?
No, you're thinking about it correctly. Yeah, it's I apologize. I go to this. The provider tax brings in about 1.5, and this is all provider tax, not just hospitals, of course. So it's hospitals, the nursing homes, pharma, and a little bit of the ambulance system. And that is put forward as state effort. Like a general revenue look-alike, that brings down $3 billion extra federal funds that we wouldn't have if not for the provider tax. So we would have to replace the provider tax with general revenue somewhere in the area of this $750 million to get the same drawdown from the federal government. And if that was to go away, then we would lose, in the order of about $4.5 billion for the Medicaid program altogether. So it's quite an enormous impact. It's almost unfathomable how it would impact us and how we would make up for it.
Thank you.
Yeah, and so to think about it, we would have to cut education, we'd have to cut roads, we'd have to cut something else to fund the Medicaid program.
Other questions, either pop them in the chat or you can just come off of mute and ask Brian. We love some doom and gloom on a Friday afternoon.
You like the Grim Reaper?
Okay, hearing none. So yeah, as thank you to Brian and Zill, this has potential to be quite devastating. And so we here at the Rural Health Association, we are partnering with many organizations throughout the state, or having in-depth discussions about this. As you know, we follow what's going on at the federal level. NRHA has been keeping us well informed. Oh, there's a question in the chat, so I'll see. Has the state identified any efficiency savings that would counter these cuts?
You know, our budgets have been tight. We've gone through a little period because of the pandemic where we had a lot of money, extra money, and we set it aside, and we've been kind of spending down our surpluses. And so it kind of masks the reality that we don't have enough revenue to really fund our budget. We've been using about $2 billion of pandemic funds in place of general revenue for the last 3 years in our budgets. So we're already $2 billion behind. We will use the last of the surplus this year. So the next year we will have to have a cut of about $2 billion just to maintain the budget as it is, with no longer being able to use those surpluses. And so then looking beyond that, where's some efficiencies out there? Very hard to see where that might be. We would probably have to start to resort to having reductions in reimbursement rates for hospitals and other providers. We may see having to get rid of non-mandatory benefits. The biggest one, well, not the biggest one, but the one that's probably kind of in front of our faces would be dental. You know, right now we have a dental benefit in our Medicaid program that's working really well, and unfortunately, it's not mandatory. The other big non-mandatory part of Medicaid is pharma, but if you reduce, or if you get rid of pharma, then you know all the diabetics end up in hospitals, and it costs you more to operate it. So that's not even an option. So it's very hard to see where this would be. Some therapies that are non-mandatory, but really I think we'd have to go through cutting eligibility where we can. There's not much savings there. Getting rid of the Medicaid expansion, somehow going back to a vote of the people to do it, very difficult to do. But provider reimbursements and making it harder for everybody on the phone here to deal with that, as you know, our reimbursements are not generous right now. So just more pain.
I'm assuming that this would also affect the pregnancy Medicaid as well.
It could, yeah.
Yeah, that would be a nightmare. Like all of my pregnant patients are on that.
Yeah. And then the 12-month continuous afterwards, probably be on the chopping block, and other difficult decisions to be made. It's just hard to see where there's not a lot of fat on the bone in our Medicaid program. We've been, for the last 20 years, been going through really difficult budgets in Medicaid, and it's hard to see where there's any savings at all, other than just cutting people and provider rates.
And then there was another question. Has the state talked in general about how they might deal with cuts in this magnitude? Any options being discussed, or are they in waiting mode?
They are in waiting mode. I've had discussions with Todd Richardson, our Medicaid director, and he realizes this is a budget buster. He's assured me that the governor and other governors in red states are advocating for other options than busting the budget, but not really. They look at maybe in a block grant scenario, there would be flexibility that they could maneuver around, but it's just very hard to see what they can do. One of the big things that Zill mentioned is the state directed payments. That's something Missouri's kind of been moving in a certain direction on. If that would be limited, that would make it even harder for Missouri's Medicaid program, and some of the efficiencies that they hope to see come out of that. Incentivized payments for providers, and bundled payments and that type of thing. All of that would be disrupted pretty much with this program as well. And so very difficult to see how some of the efficiencies that the state had been working on can continue with changes such as this.
And then as a follow-up, in 2005, when we cut Medicaid in large amounts, we raised premiums on those that do pay premiums. That is an option too, right? Was there any changes in the ballot initiative about that, or when that was changed?
Can you repeat that, Heidi?
That was my side little question. Was there anything in the ballot language whenever we put this into the Constitution that affects that or anything?
No. There's language in the ballot initiative that would restrict work requirements. And so that's another issue. If we have a work requirement coming from the federal level, we would have to deal with that because as of right now, Medicaid expansion cannot have any restrictions or any onerous requirements placed on it that other categories of Medicaid participants have. So we couldn't just apply work requirements to our Medicaid expansion population. We would have to figure out how to deal with the work requirement for all populations. So that's another thing that would make it very difficult to figure out. So we're in a very strange place, and it's hard to kind of see through the looking glass on where we end up in the different kind of variations of changes they may be making. But Missouri's going to be in a harder spot than most.
And then another question, what percentage of adults on Medicaid already work? That's actually wouldn't make a lot of difference, would it?
Tim? It's a significant amount. Tim would know, he's the numbers guy.
Yeah, it's, most studies put the number at about 80% or so of the non-elderly 19 to 64-year-olds. So if you cut out the kids and the age 65, I would have presumed that we're not going to do a work requirement on elderly or kids. Then if you're talking about 19 to 64-year-olds, most of them are working already. So we've done 2 or 3 studies of this, and you're really talking about a fairly small percentage of people on Medicaid that are actually not working already. And a lot of them are either disabled, at least they identify as work disabled, or they're in school, or they're caregiving. And, in the past, when the state has considered putting on a work requirement, they've put all 3 of those categories into exclusions. And then you're talking about just a few thousand people that would be eligible for a work requirement. But I've heard that they may not even allow those exclusions. So, but anyways, to Cindy's question, I think it's entirely right that the percentage of people in like the expansion group and the custodial parents who are not working already is pretty small.
With regard to the budget on work requirement, it doesn't have the same kind of negative budget impact to the state because we would actually lose a lot of people because of the reporting requirement. The administrative problems that a work requirement causes for the state is where you start to lose people because they can't report the work, they can't get through to the call center, they can't get through to the website, and people lose coverage. That's what we've seen in Arkansas when they tried to have a work reporting requirement. But that seems to be very likely. Everybody's saying at the national level that we're going to expect to have a work requirement. We'll have to figure out what the administrative burden of that will be and how we deal with it. But it's not a budget buster as the other ones are.
Yeah, if I could just jump in and add, Brian, I mean, the national numbers they're talking about, I think, are around $100 billion, but that's over 10 years. So, that's a lot of money in Washington, but that's not a huge percentage of the Medicaid budget. When you get down to the state level, they're not assuming a bunch of change from that. That's not where the big changes are going to come from. It's FRA and it's the FMAP stuff.
And if I can jump in here just briefly, which is that in the conversation around employment tied to Medicaid, it doesn't really change a lot of that budgeting process that much, but it's going to have a significant impact on who gets the coverage, right? And that's where you're going to start to have that problem, where it's the underinsured issue.
And more acute in rural areas because it's fewer big employers that carry insurance for people. So
Yes.
Yeah, I see the work requirements as quite devastating for our rural communities. Back very early in my career, I was a caseworker who worked with TANF recipients who had work requirements. And one of my counties that I covered was Osage County, which is very rural. And it got to be such a challenge for folks, whenever they were trying to look for work, but they didn't have a car, or their car had an issue, or they had trouble trying to find childcare. It just got to the point where most of them took the deductions because they couldn't meet the requirements in the job search. There's only so many places to apply for, and once you apply for them, you're not allowed to apply at those same places again for a certain amount of time. So, if there's 5 places for you to apply for and you get through all of those, then what do you do? So we are monitoring that very closely and its impact that it'll have in rural communities. And I think it's just going to be devastating. Other questions folks have? Give it a second here.
And I'll just fill a little bit of time. The Medicaid expansion was part of the Affordable Care Act because we have this kind of inverse correlation between in an employer-based healthcare system. The people that make a lot of money don't need to buy insurance, and people that make low wages have to buy insurance, but they don't have the money to do so. That's why we had to do Medicaid expansion, because this inverse correlation between who's offered healthcare in the workplace and who's has to buy it on their own. That is magnified 1,000 times in rural areas. And that's why, you guys have been so great making this message known and doing the good work that you've done.
Okay, I'm not seeing any other questions in the chat. Last call for anybody who wants to come off of mute. Otherwise, it is about the top of the hour, so I figured this discussion would take the whole hour today. So I want to give a special thanks to Brian and Zil for joining us today, and Tim for throwing in some of his expertise in there as well. He has some great research and information on this topic as well. So we want to thank everybody for attending today. We did record today's presentation, so we will get that sent out, as well as any of the PowerPoints. As long as Zil and Brian are okay with sharing those with us, we will get those out to everyone within the next couple of days. And so next month we do have our end of the month one next month. However, we might have to switch the time of that, but we will keep you all posted on that. So feel free to check out our website for upcoming events and upcoming lunch and learns. These are free of charge. We do this as a service to our rural communities, offering these weekly lunch and learns, sometimes twice a week lunch and learns at no cost to folks. So we appreciate your support of the organization so that we can continue that. All right. Thank you so much, everybody, for attending today.